started. Well, thanks everyone for joining us. As you know, the seminar is held on the second and fourth Mondays from September to June. And if you have would like to speak or have any other ideas for speakers on research in child health, please let me know via email. Looking ahead to our next speaker on May 22nd, we'll be welcoming Dr. Betsy Crouch from the Division of Neonatology. We are still virtual and using Zoom, so we'll ask you to stay muted unless you have a question, and we'll open it up to at the end for questions as well. And Betsy took off her camera and waved to us to identify herself. So, perfect. Today we're welcoming Dr. Matt Pantell from the Division of Pediatric Hospital Medicine, the Social Interventions Research and Evaluation Network, or SIRN, and the Center for Health in the Community. Matt is an assistant professor of pediatrics. His research focuses broadly, soon to be associate, excuse me. His research focuses broadly on social determinants of health and social needs, with direct investigations into social needs screening and the incorporation of social information into clinical decision-making. He holds a K08 award from the Agency for Healthcare Research and Quality. The title of his talk today is Integrating Social and Medical Care in the Pediatric Inpatient Setting. Thanks for joining us.
Thanks, Roberta. Appreciate it. Let me just share this here. Right. Give me one sec. I'll do new share. Right. Does that look like the right mode?
That looks good.
Okay, great. All right. Well, thanks again for having me to this series, Roberta, and I look forward to questions at the end. So today I'll be talking about integrating social and medical care generally, but focusing a little bit more later on the pediatric inpatient setting where I do most of my clinical work. All right, let's see here. And I have no competing interest to declare. As I told Roberta before, I've not found it lucrative to study social drivers of health among children, but if anybody knows a way, I'm happy to add to this slide. So I'll first start by talking about relationships between social drivers or determinants of health and child health outcomes and some terminology. So social drivers or determinants of health are the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. I put drivers / determinants because the field is now using the term drivers more than determinants to make it less deterministic. That's saying that if you're exposed to certain social drivers of health, you don't necessarily have adverse health outcomes. But so I'll refer to SDOH as both of those terms in this talk. Adverse social drivers or determinants of health are what we call social risk factors, and they're related to a variety of negative health outcomes among children, and in the inpatient setting have been shown to be associated with a longer length of hospitalizations. Social needs are the social risk factors for which families would actually like help addressing. And, after identifying social risk factors, it's not always that families actually would want services related to that. So we differentiate those with social risk factors versus social needs. And there's a lot of work that's shown how social risk factors are related to health outcomes, and also how they're what we call social gradients in health, meaning that the more sort of social adversity you have, there's sort of a dose response related to risk of adverse health outcomes. So this is a summary of this by one of my mentors, Dr. Nancy Adler and colleagues, showing that as socioeconomic status increases, rates of or the prevalence of a lot of different health outcomes among children decrease, including chronic conditions, asthma, ear disease, injury. And it's intentional that I have this as a reference from 2007, just to show that this has been shown for many, many decades now, these social gradients in health. And similarly, we see that a lot of social risk factors don't operate alone, and that a cumulative effect occurs whereby the more social risk factors children are exposed to, the higher the likelihood of having many health outcomes, including sort of worse overall health, worse dental health, social emotional problems, and then being overweight. And there's more and more work done looking at the biological manifestations of social drivers of health among children. And prior work has shown that socioeconomic status is associated with abnormal cortisol patterns, whether they're either very high cortisol or very low cortisol. And other work has shown that high social adversity is associated with shorter telomere length among children, sort of representing damage to the ends of chromosomes. And we recently were looking at this in a sample at ZSFGH and looking at a variety of different biomarkers, including endocannabinoids and epigenetic clock and inflammatory markers. And what we found here is you can see that the more cumulative social adversity children experience, the higher the likelihood of having high levels of many biomarkers, especially those having 2 to 3 social risk factors here. So you can see, looking at IL-1, IL-6, and IL-8, there's sort of increase in the level of these inflammatory markers, as well as TNF alpha, with especially among those with 2 to 3 social risk factors. For cortisol and cortisone, which is an inactive metabolite of cortisol, we saw that it was actually those with the higher social risk factors had lower levels, although wasn't quite significant for cortisone, and which we suspected was sort of or hypothesized was related to sort of the cortisol blunting effect after chronic exposure to social adversity. We're working on that paper now. So sort of talked about the associations of social risk factors and health outcomes, but it's also important to know the burden of social risk factors among children. And this is actually looking at before COVID. There was nearly 1.6 million children every year that experience unstable housing, with 14% of children living in households experiencing food insecurity and 4% missing medical appointments due to transportation challenges. And again, this is before COVID, and we know that a lot of social risk factors have increased during and after COVID as well. Focusing more on the population I work with, hospitalized children, there's not a lot of work that has examined sort of the prevalence of social risks among children that are hospitalized. Some studies have done sort of single center chart reviews or used ICD codes, which are sensitive, or they're specific but not very sensitive. So we don't really know the burden of social risk factors among those recently hospitalized. But we did recently try to look at a proxy of this, looking at the National Survey of Children's Health, which is a survey of, in 2020, we looked at it was about 47,000 caregivers of children ages 0 to 17. And one of the questions asked, was your child hospitalized within the last year? And we compared rates of social risk factors among those that answered yes to that versus not. And you can see here that in red is the children that were recently hospitalized, and blue is not. And children that were recently hospitalized had significantly higher rates of financial strain, food insecurity, having childcare issue such as access to childcare, and having problems paying medical bills, as well as having any risk or having 4 or more risks. Interestingly, the children who were recently hospitalized reported lower rates of not having emotional support. So caregivers actually of hospitalized children had higher rates of emotional support compared to those not recently hospitalized. But overall, most social risks were higher in among children who were recently hospitalized. And then looking at those children that were recently hospitalized, which is about 1,200, and the survey allows you to do sort of national weighting to make it representative of the population of the US. So we looked at that subset of 1,200 children recently hospitalized and found that there were a few characteristics associated with higher odds of having a lot of social risk factors, including children with special healthcare needs compared to those without special healthcare needs, and then children with public insurance or uninsured compared to those with private insurance. So moving along to sort of how we address this in the healthcare system, I wanted to talk about sort of the recent approaches to integrating social and medical care. And a lot of this comes from 2019 National Academies of Sciences, Engineering, and Medicine report that was led by Dr. Kirsten Bibbins-Domingo, who is now the editor of forget which of the JAMAs, but the JAMA network, and I think all JAMA, and is still Epi Biostats faculty here. But this report really talked about how healthcare system activities can strengthen social care, and talked about this, what they call the 5A framework now. And the 5A framework, I wanted to take the time to go through the slide because it really is helpful in determining how you can approach this and how you can do research on this. And this is a summary that Dr. Bibbins-Domingo put out in JAMA right after the report came out. So the 5A categories include awareness, adjustment, assistance, alignment, and advocacy. And so they have a great table of applying this example to transportation in the report. So or in the JAMA paper. So awareness involves identifying the social risks and assets of defined patients and populations. And so the transportation example would be asking patients about their access to transportation. So this is what we think of as screening. Adjustment is activities that focus on altering clinical care to accommodate identified social barriers. So this would involve reducing the need for in-person healthcare appointments by using other options such as telehealth appointments. Assistance is activities that reduce social risk by providing assistance and connecting patients with relevant social care resources. We think of this as sort of referrals. And the example is providing transportation vouchers to help patients get to appointments. These two things, adjustment and assistance, I think, and we usually think of assistance a lot more, like once you screen, if someone screens positive, giving them something like a voucher, or if it's food insecurity, giving them food or a referral to a food bank. But I think a lot of the time, we as healthcare clinicians are actually providing adjustment once we know about these social risk factors. We're just sort of, I think, less good at naming that we did that. But I think a lot of us do that, especially in the hospital setting when we're thinking about discharge and trying to figure out the best way for patients to stay out of the hospital and get good follow-up. Then there's alignment, which is activities undertaken by healthcare systems to understand existing social care assets in the community, to organize them to facilitate synergies, and to invest in and deploy them to positively affect health outcomes. So for this example of transportation, it would be to actually invest in community ride sharing as a healthcare system. And then advocacy is activities which healthcare organizations work with partner social care organizations to promote policies that facilitate the creation and redeployment of assets of resources to address health and social needs. So this would be working to promote policies that fundamentally change the transportation infrastructure within the community. So, advocating to the city to get a bus line to a place where patients are in a transportation desert, things like that. So those are the 5 A's that the National Academies report put forward. And I'll talk about some of the work going on related to this framework. So the first I'll talk about is awareness. And again, awareness is essentially synonymous with screening, so that you understand, whether or not patients are having social or experiencing social adversity. So there's a lot of professional organizations that now endorse some sort of screening for social drivers of health in clinical settings, including the American Academy of Pediatrics and the Children's Hospital Association. And in the last 6 months, there's been a lot of standard setting organizations that also have started endorsing this. CMS has started endorsing screening for a lot of social risk factors, but only for patients ages 18 and older. But the National Committee for Quality Assurance has recommended screening for food insecurity, housing instability, and transportation needs. And the Joint Commission is also advocating for screening and community resource information provision on social risk factors that the hospital chooses. So there's a great article by one of my mentors, Dr. Laura Gottlieb, going over about 5 of the standard setting organizations, either new or about to be enacted recommendations this year. Also, U.S. News and World Report is now actually awarding points for social driver of health screening, so now a lot of hospitals are also interested in learning how to do this effectively. But not a lot has known about what children's hospitals are actually doing, because we just have not had good data in the past. And so we recently tried to figure this out to look at a baseline before all of these policies were enacted, what has been going on. So we actually used the American Hospital Association annual survey from 2020, which actually started asking in that year. They asked hospital CEOs or whoever the CEO delegates to answer the survey questions. Do you routinely screen for social needs or social among your patients hospitalized? And so what we found is that there's sort of a range of rates of screening based on the domain. They ask about housing, food, utilities, transportation, employment, income, education, and social isolation. You can see it ranges from 49.2% of children's hospitals saying that they screen for employment, income, to a high of 67.5% screening for housing. And about 80% screen for any of these, and about 50% screen for 5 or more. When implementing these sort of screening protocols, a lot of people ask, are patients comfortable about it? And on the whole, they are. So this is a study done by my colleague Amelia DeMarcus and Siren that interviewed or surveyed patients and caregivers at 10 hospitals throughout the U.S. in the primary care and the emergency department setting. And what they found is that overall, most people found that it was somewhat or very appropriate to screen in those settings with, if you added neither, you had a little bit more in terms of people that weren't really finding it inappropriate. So there were small rates overall of finding that it was inappropriate, somewhat or very inappropriate to screen, so less than 10%. Interestingly, and I think this is important when we're thinking about how to do this and whether or not to document it, when asking patients about including this in the social risk information in electronic health records, a little more discomfort, so going up to around 20%, depending on the setting here. So patients overall seem pretty okay with screening, and also pretty okay with having this information in the EHR, the less comfortable than having just screening in general. So that's sort of some of the state of screening among children's hospitals and clinical settings, but we know a lot less about adjustment activities, because as I said, I think a lot of us as clinicians do this, and we just sort of don't document that we're doing it, or are just so used to doing it that it's sort of implied that you're thinking about it. But we have been interviewing clinicians about how they adjust clinical care. We're doing a study right now interviewing San Francisco Department of Public Health clinicians at several clinics about this, and the interviews are ongoing, but we find that clinicians are doing some adjustment. For example, for unstable housing, they talk about it whenever they identify patients with unstable housing. They collect multiple addresses and phone numbers so that they can try to contact the patients where they are, because a lot of times they're couch surfing or they're staying with relatives. And so they usually write down, 4 or 5 ways to contact them, because they worry about losing their ability to contact them for follow-up. And then, they also talk about when they know that patients have unstable housing, and that they should, get lab samples at the same day at the clinic lab, so that they're not, because they're at higher risk of being sort of lost to follow-up. So there are care adjustments that people have been doing already without even sort of recommendations about it. And then we also are trying to figure out from the chart, what care adjustment activities people are doing. And to start doing this, we just want to see, who's even taking in this information. So we did a study that was led by Mike Wang, who's in the adult division of hospital medicine. Looked at this a couple of years ago and looked at 5 different places that social risk information is charted in our EHR. So one is sort of through the the problem list, so where you can put a diagnosis code of unstable housing. One is in this sort of these icons in the EHR that what's also called the wheel, because they're usually shown in a wheel in a circle of availability. And so there are places to document financial strain and food insecurity in the EHR as well by clicking on these buttons. You can free text it in a social documentation section of the chart. You can also in our EHR, especially in inpatient setting, all patients, when they're admitted, nurses go through about 20 admission questions, including one of them, which is housing status, and you can document that they do not have housing. And we also looked at social work notes. And so what you can see here, and this is looking at about 36,000 inpatient encounters at UCSF from February 1st, 2019 to February 1st, 2020. And what we see here is the percentage of those hospitalizations that had some sort of social documentation that was there. So you can see that the problem list, where you can put in ICD codes, there was only about I should say that the light blue in these things represents stuff that was documented before the patient was admitted. So they might have had, looking at the middle here, a social work note in the past. The dark blue represents something that was documented during that hospitalization, and the gray is sort of like looking at all of it. So you could see that starting on the far left, those ICD codes, only 0.3% of encounters had an ICD code documenting a social risk factor. That was the wheel. So only 0.3% of them had those icons. 0.6% of them had an ICD code, and then about 50% of encounters had a social work note. But only 27.5% of those were actually during that admission. The rest had occurred during a previous healthcare encounter. That social history free text, you could see about 49% of patients had something there, but only 12.1% had new information added during that encounter. So the rest of it was from healthcare encounters from before. And then the patient nursing questionnaires, you could see there was 88.5% of patients had some data, and most of them, 86% of patients, had sort of new data that hospitalization. So very, very current data obtained through the nursing documentation. And then looking here, this is looking at those among those patients that had data available, who looked at it. So we looked at who clicked on the screens where that data was stored. And what you can see here is the green represents the percent of the encounters that were looked at before discharge. So you could see it's not quite 0% here, it's just so small, but 11% of those icon documentations were reviewed. About 21% of those that had ICD codes had page reviewed where they were documented. So 70%, remember, it's 35.6 of the 50% of encounters. So 70% of patients that had a social work note there did have it reviewed. So pretty high rate there. And then among those patients that had social history text written, about 30% of them had someone open that and look at that. So we couldn't look at the inpatient questionnaire there, but so we're trying to see signals of, where is this social information most visible, and where is it most commonly accessed, so that we can ensure clinicians are able to adjust care and know about the social risk factors of their patients. We think it's important now. This is just a signal. It's not we don't know exactly what patients do, but when we did look at patients for whom their clinicians looked at social information as documented in one of those places I just showed you, what you can see here is the percentage or the readmission rate over time. So at the top left here, this is the percent of patients that are not readmitted. So on day one, 100% of patients are not readmitted. And then you can see over time, those patients, after they're discharged, the percentage of them that are not readmitted goes down. So in other words, this is sort of a curve showing the readmission rate. And the red line or the blue line represents patients for whom their social information was not viewed by a clinician. The red line represents those patients for whom the social information was reviewed by a clinician. So again, it's fairly messy data, but what we sort of hypothesize is happening here is that patients that are reviewing the social data are doing some of those adjustments and providing social resources such that they can hopefully lower their odds of readmission by connecting them to the proper resources in the outpatient setting. Again, hard to say, but sort of a starting signal. So now I'll talk about assistance. And this is, again, sort of I think the typical thing we think of and how to respond to patient social risk by, giving them resources to address those risks directly. And I think it's important to note that there is, evidence out there, increasing evidence that shows that, addressing patient social risks can improve health outcomes among children. So Dr. Gottlieb has done a randomized controlled trial showing that patients that had a social risk navigator assigned to them to help them connect them to social resources, and this was done at San Francisco General Hospital, they showed that the navigator arm had lower rates or had improved health over the next several months compared to the control group. And I led an analysis of these data showing that you can see on the left side here, this is looking at the admission rate over time of those patients for those in the intervention group that were assigned a social needs navigator and the control. And what you can see is this is sort of the opposite of what I just showed you with the Kaplan-Meier. So we're going up and this is the percentage of people being admitted over time. And you can see that the intervention group is being admitted at a lower rate than the control group here. And we replicated this in a San Francisco General sample again a few years later, showing, and the editors of this journal wanted it flipped, so they wanted to show the time to going downwards, but essentially they're the same thing, showing that those in the social navigator intervention group were being admitted at lower rates than those in the control group. And in the same survey I discussed earlier, the American Hospital Association annual survey, that they asked children's hospitals, how many of you, not only do you screen for things, but do you assess the effectiveness of these screening protocols you have? And just over a third, 38.7%, said that they did assess screening effectiveness in their screening protocols. And among those hospitals, which was only about 33 in total, they actually reported that they had seen, they had data showing, or that they had assessed and found that implementing these protocols improved health of patients, it decreased the utilization, it reduced cost, that was the lowest amount, only 39.3% of hospitals saying that, and it improved community health. Now, we don't know how they were measuring it, but they essentially, for 3 of these outcomes, over 50% of those measuring said that they found benefit in sort of doing these screening protocols in children's hospital settings. The literature is pretty light on this, so we have encouraged in this paper that's in revision people to share this data so we can learn sort of best practices about what people are doing. And it's also important to know that these screening for and addressing patient social needs can actually also have or is associated with benefit among healthcare workers as well. So we've done a study, and again, my colleague, Dr. DeMarcus, has done a study showing that the capacity of healthcare systems to address patient social needs is actually associated with higher job satisfaction, better perceived quality of care, and less burnout among healthcare workers. So in response to this, there's a lot of work now going into using EHRs to facilitate referrals of patients to community-based organizations to address social needs. So for example, this is at SFDPH clinics, where I also work. You can see that they have these circles as well to screen. I know it's sort of small for social risk factors, and I'll read it. This is if you were screening for utilities. It says in the past 12 months, has the electric, gas, oil, or water company threatened to shut off services in your home? And you can answer yes, no, or already shut off. If the patient is then positive for one of these social risk factors, the icon turns red, denoting that there is a risk. Green means there isn't a risk. Gray means they haven't been asked yet. And what will happen at SFDPH is this button for finding community resources will come up, and it has a list of about 400 San Francisco community resources that you can click on, and they are coded to be linked to, you know, whatever social risk you found, so housing or utilities, and you can then put these in the after visit summary for patients or print it out for them. Now, the uptake of this is not very high, but it is a tool there, and it just goes to show that Epic is just having this built in, you know, and they are the largest EHR, or they have the largest market share in the country. So it goes to show that a lot of these social risk screening modules are being more incorporated into these big EHR players. And UCSF Health will actually have this available in the next several months. But there are other platforms that actually are much more integrated. That's sort of a one-way referral where you're just printing this out for the patient. But Dr. Dana Long, who's at practices at BCH Oakland, you know, has developed a whole platform called Find Connect that actually it can help refer patients to community-based resources and also facilitate sort of communication back and forth about you know, those patients connecting with those resources and following up, and has some really great data tracking, so you can see what your patients, what resources your patients are accessing, and lots of other metrics to help track a sort of population health. Another one of these programs is called Find Help, which you can purchase, and UCSF has actually just purchased to use as well for UCSF Health. And there's a free version online. If you would like to use it, you could just go to findhelp.org and type in a zip code, and then you can look for programs associated with that zip code. And what it will do is then sort of give you a list of resources to address social needs in that area by wherever that patient zip code is. The free version, you can just do this and you know, print it out. In the version that UCSF has purchased, there's actually a way to then send referrals such that the community-based organization receives them electronically and can write back and say, you know, the patient's social need was met. So you can sort of see if your patients are actually, you know, accessing these resources in the community. So then it's worth knowing how, you know, whether hospitals actually have something in place once they screen. And again, a lot of the standard setting organizations now are recommending screening, but they're not including metrics for doing things about screening once you have completed the screening. So in that American Hospital Association survey, we also looked at, you know, what percentage of children's hospitals have strategies in place to address social risks or needs once they're identified. And we also found, you know, variation by the social domain, with the low of 44.8% having something in place to address employment and income, with a high of 71.5% with something to address social isolation. Interestingly, even though only 80% of hospitals said that they had a sort of a screening protocol, almost all of them, so 94.6%, said that they had a strategy in place to address social risks and needs. So it seems that actually there are more strategies there than there are screening protocols. And you know, about half of them as well had 5 or more strategies in place to address social risks. Looking at, there's just a little bit of work that is looked at how community-based organizations partner with healthcare systems to address mutual patients and clients. So we were also interested in seeing, you know, especially in the setting of all of these new electronic health record referral platforms, you know, how closely are children's hospitals already working with these CBOs? And from that same survey, what we found is that they asked about whether or not external or healthcare systems partner with external organizations, including faith-based organizations, food organizations, housing organizations, transportation organizations, legal organizations, other nonprofits, K through 12 schools, colleges, universities, and local businesses. And you can see there's a range of partnership there, ranging from a low of 27.7% of children's hospitals partnering with local businesses to a high of 62.2% partnering with other nonprofits. And this is, you know, the question was asking is, do you partner with these organizations to meet patient social needs through things like referrals? So now moving on to alignment and advocacy, we sort of finished the assistance and what we know, which is, I think we know the most about assistance, though probably least about adjustment and some about alignment and advocacy. This is showing, again, partnership between children's health systems and CBOs. And the blue is what I just showed you. So, how commonly children's hospitals partner to address patient social needs, again, from the American Hospital Association annual survey. The red is asking hospitals, how commonly do you partner with these organizations to implement community initiatives? So what you can see here is that, in general, far less participating with CBOs to implement community initiatives, with a low of 18.6% partnering with local legal orgs, to a high of 47.1%, again, partnering with other nonprofits. And the way that we sort of took this is that, there's a lot of, and this is sort of what we're hearing from CBOs as well, is that there's a lot of interest in healthcare systems in general to partner with CBOs to help address, patients that the healthcare systems identify social needs for and sort of refer them to CBOs, but there's less partnering with them about doing things in the community or outside of the hospital setting where healthcare systems have traditionally not really participated in that sector as much. So this is just, again, showing that difference between the community initiatives and sort of initiatives to address individual social risks. And we have finished interviewing, as part of a project, interviewing a bunch of staff from 35 CBOs in San Francisco and asked them about their experiences partnering with healthcare systems to address mutual patient and client social needs, and how they feel about getting these referrals. And some of the initial themes that we're just starting is that there's sort of insufficient funding and staff to support and address referrals oftentimes. That there's a need for more collaboration and two-way communication, not just one-way referrals coming to CBOs. CBOs have privacy concerns related to the storage and sharing of data and what they can share and receive data about. And health systems need better understanding of what CBOs do before referring. We pretty consistently heard that a lot of times they get referrals and patients aren't eligible for that CBO, and that if there was a little more time done triaging, it would really help the CBOs with all of the referrals. And they also discussed desiring a point person in the healthcare system. So again, sort of goes back to not just a one-way communication, but that they appreciate partnerships where they can then get in touch with someone in the healthcare system to talk about any issues coming up from referrals. Towards the end here, I wanted to talk about more local initiatives that are happening, in case people are interested. And this is just some of the work, much of the work that's being done on sort of integrating social medical care here. So first of all, there's a UC Health SDOH Workgroup, which is part of the University of California Office of the President. And this has representatives from all the UCs that have hospitals, and their goal is to assess shared data, shared tools and methods. So, and what they did is help to figure out a vendor for electronic health referrals to social needs. And they're also defining SDOH needs within populations, UC populations, with the goal of implementing a core set of screening and domain questions. And related to that, they have endorsed that all UCs screen for food insecurity and for food quality, if possible. So not just that you have food, but it's if you want to get nutritious food, you're not in a food desert. They'll likely endorse other domains this year, considering financial strain and food, social isolation, as well as the other domains that a lot of the standard setting organizations are endorsing. There's also a UCSF Health SDOH task force led by Malcolm John, and this is really trying to coordinate, social care integration practices among all the UC hospitals, and proposing the development of an overarching strategic plan. And so that is, again, looking at sort of both adult and child populations and what we do at the UC system. Dr. Ondekwo leads the UCSF Pediatric Social Needs Task Force, which is a great group that has people that are working in all the different clinics, including Mount Zion, San Francisco General, Mission Bay, and BCH Oakland. And it's a great place to sort of share best practices for what people are doing in their different clinics and units that are focused on pediatrics. And then this is just to highlight a little bit at San Francisco General of Dr. Amy Whittle and Phil Herrera lead the Health Advocates program, where there are health advocates, which are essentially social needs navigators that screen patients and provide resources. And what's great is that they can clinicians there can refer patients to health advocates to follow up with patients via email and via the EHR. And so this is just looking at, they do a lot of data collection at patients and how they screen for what social needs they screen for and how they've changed over time. And then in our local inpatient unit, Dr. Nora Pfaff and I lead the social needs task force, where we, during COVID, sort of put together this, or gathered this committee to figure out a standardized approach to social risk screening and figure out protocols to do this at C5, our med-surg unit at Mission Bay. And what we came up with initially, and this is changing, is that nurses will screen all patients for financial strain on admission. Those families that are endorsing financial strain would be screened for food insecurity by physicians, and then social workers would screen for other social risks as part of their assessment. And so this was trying to get everybody kind of to do one part of this. And we were fortunate to have a lot of help from informatics teams, and having things like adding this column where you can see if it's green if people are not financially strained, and it's red or yellow if they are. And so you can look at your patients and triage who to go speak to about food insecurity. Dr. Eris Oates was instrumental in getting us to have a little checkbox added to the to-do list about food insecurity screening. And we created, thanks to our social work team, a website with food insecurity resources by the 8 most populous counties that in terms of patients that are admitted at UCSF. And so these are available online at tinyurl.com/PHMFoodRes, and you can see statewide and local food resources, and we have these available to print. And then there's also families that were needing food that night. There's things like the SF New Deal has something where you can text a center for a meal, and they partner with local food organizations and restaurants to get families a meal for that night. But it is, as all implementation science, we found things we did and did not expect. And we did a bunch of PDSA cycles. And I know this is a busy chart. This is looking at the percentage of patients screened here. If you look at the line in blue, this is the patient screened for financial strain, which again is nurses sort of doing this on every patient when they're admitted. And you can see it's pretty inconsistent until right here, week 21, which is essentially, that's when that question was incorporated into the admission questionnaire for nurses. And after that, it's been hovering at about 90% because, they just are going through and asking it with all the other questions they ask. The red is showing the percentage of patients being screened for food insecurity among those that are financially strained. You could see that us as physicians are much more inconsistent, and many cycles have gone by and we're still sort of hovering at around an average of 20%. So a lot of room to grow there for us physicians. We did find, our intervention, we increased rates of screening, and that our overall financial strain positivity rate was about 1 in 4, so 24.6%. Among those that are endorsing financial strain, 54% of them endorsed food insecurity, and we started to see some differences in utilization. Financially strained patients staying about a day and a half longer. The good news is about 55 to 75% of food insecure patients had documentation of getting resources. So we are hoping that we're under documenting and that all those patients are getting them. But in terms of documentation, it was about 2/3. So next steps, we want to sort of do PDSA cycles to improve the food insecurity screening, and we're trying to partner with some food provision partners, and eventually it'd be great to expand like the Health Advocates program in ZSFGH. They have at their website, which you can look at really for each of the different social risk factors they screen for. They have these amazing flow charts of how to get patients hooked up with resources. So I think that would be the ideal state eventually. Lastly, I will just mention that Roberta mentioned, just was fortunate enough to get a KO8 to for the project addressing unmet social needs among hospitalized children. And so this is now, got the money about 3 or 4 months ago. So we're doing these aims right now. And the first one is to use EHRs to examine associations between unmet social needs and unplanned healthcare utilization among hospitalized pediatric patients. And again, trying to fill that gap of we don't know as much about social risk factors in the inpatient setting. And this will use natural language processing, which is a tool to sort of search note text for social risk factors. Because as discussed before, some of the documentation of these and these sort of ICD codes or these social needs modules is less consistent. So this is a paper by Navaith and colleagues 2018 showing that among social and behavioral risk factors, if you look at ICD codes here, that's in black, the percentage of patients that had social risk factors documented. This is among adults with heart disease. So you can see in housing instability is about 1% there. Poor social support was 0%. And then when you look into actual notes, you can see the gray is the additional prevalence that you uncover. So it increases, this is all just to show that in these data elements like ICD codes, you're far less likely to see things than in the notes themselves, which is why we're looking at using natural language processing. The other things that are ongoing now, and aim 2 is to use qualitative methods to explore caregiver and care team member perspectives on screening so that we can do a better job in the inpatient setting. And Dr. Salman Dali, I'm working with, is first-year pediatric hospital medicine fellow, and she's doing a lot of this work with me to interview and discover sort of the best practices and preferences. And then aim 3 is going to be a pilot trial to sort of implement an inpatient social needs screening and intervention protocol at the hospital. So for my next steps, I need to complete the K08 aims, and then the hope is to sort of leverage to an R-level grant expanding on the pilot work. And we're also exploring the effect of addressing social needs on biomarkers of disease. So what I showed you was that those biomarkers of inflammation, that was sort of initial associations, but we're seeing if the navigator interventions actually have any influence on these biomarkers of disease. And then I've been really interested in sort of social informatics and how to leverage the EHR to address social risk factors. So we're looking at the effect of implementing social needs referral tools in electronic health record platforms and seeing if they do indeed help get patients to the resources that they need and how it influences health outcomes. So in summary, I hope people take away that addressing social needs can improve child health and can reduce hospitalizations. That recently hospitalized children are likely to have relatively high rates of many social risks compared to those not recently hospitalized. And currently there's wide variation in children's hospital social driver of health screening and intervention practices. And it'll be interesting to see how that changes over the next few years with these standard setting organizations. And that developing best practices for pediatric inpatient SDOH screening will require family healthcare staff and CBO staff input, I think, to be most effective. And so I wanted to thank funders here, and as well as my mentors, Laura Gottlieb, Nancy Adler, Jeff Feynman in particular, and thanks to Suni Kaiser, my division chief, and Dr. Hirsch for supporting me during the K writing process, and particularly for my parents and my partner Amanda for helping support me and my sanity during the K writing process. So thank you, and I think we have time for questions, and you can email me with questions as well.
Yeah, thanks, Matt. That was great. While we're waiting for others, so I was intrigued by I was getting a couple of texts while this is happening, but I was intrigued by the fact that you said that providers have higher rates of satisfaction and lower burnout when they're able to address social determinants of health, but then also thinking about how poorly so far we've been able to uptake that on the provider side. And, of course, contributing to our burnout is sort of the need to complete things and check them off and all those other things that we do when we're taking care of patients. And I'm just curious how you think about implementing these things effectively.
Yeah, that is a great question. And actually, let me just share for one section. So So the way I think about it, and the first thing I'll say is that we're trying to explore that more in the qualitative interviews we're doing with care team members now. I think the way I think about it is that screening, like adding another thing for people to screen is, as we know, it's just very hard. We have so many things to do. I think the capacity to address social needs study there speaks to if you're doing any screening, or if you're not even doing any screening, but if you identify social risks, even if it's not a protocolized thing, how people feel really disheartened if there's nothing that you can do about it. And so let me just show. So I didn't show this, but this is our can you see that, Roberta? Yeah. So this is just the pre-pilot survey on the ward here of different, it was nurses, residents, attendings, everybody. And you can see this is like basically saying, do you think this work is important? I'll sort of paraphrase here. And almost everybody was like, we strongly think this is important. But if you look at sort of the barriers, a lot of it, and you can see here is, unsure whose role it is to address, inadequate screening tools and lack of training and how to respond was very highly over here, and lack of resources to address SDOH once they're identified. So I think a lot of it is related to that, is like, if we don't have something in place once you screen, it just feels again just sort of disheartening and can really lead to a lot of what I think contributes to burnout there. So that's my take, but hopefully we'll get more info with the interviews.
Yeah, that's a great thought. Okay, so Liz says, such great work, Matt. It's in the chat. And then Naomi, go ahead.
Yeah, also agree. It's so great to see it all put together in one presentation. It's really awesome. I was reflecting on that graph also with the provider and the nursing piece, and I just went to the APA QI meeting, and it's a similar pattern to what we see in a lot of QI, which is that when you have an electronic health record kind of decision support aid, it makes a massive difference. So you see that huge up spike, and it's not because they're trying harder, they're better at their job, they care more about it, they feel like they can do something about it. It's just that they have this thing that's reminding them to do it, and it's part of their workflow. So I would probably say, if you want to do the same thing for the MDs, you just have to implement something that creates it makes the right thing to do the easy thing to do. Right. Rather than worrying too much about like, oh, are we getting them all the resources that they need? I think it's actually much of it is operational rather than the attitudinal.
Yeah. Thanks for the comment, Naomi. I totally agree. And we're working on the other informatics interventions now. There was something done at Brown University where they had it in, a progress note template, and it shot up a lot, so, I mean, that's less of a hard stop. And we've had talks about hard stops versus soft stops. And I think that the take right now is not a hard stop, but we're hoping that we can put through the progress note, or we even talked about like the admission, like something that comes up, not as a hard stop, but as a, that if something comes up, we would hope that the uptake would be higher for physicians. So I totally agree with you, and hoping we could find something that's we have the buy-in to try.
Go ahead, Jim.
Matt, thank you very much. Great talk. I'm interested in the biomarkers, and my question is informed by our own work on showing that the placental methylome is highly reflective of adverse intrauterine environment, a number of associations, even things as subtle as maternal mood disorder, we've shown alter the placental methylome. So I wonder what you're going to be looking at.
Yeah, that is a great question. We looked, the only sort of like epigenetic thing that we've looked at thus far is this thing that's sort of called the epigenetic clock. That's sort of looking at DNA method, which you probably know, Jim, and for others is like sort of like the DNA methylation can be markers of essentially like advanced aging if there's too much methylation. And so you look at sort of like the epigenome to see, is there more method? I'm totally, for all the basic sciences, I'm totally simplifying it, but is there more methylation that would indicate sort of advanced aging that would indicate a response to stress exposure? And so the hypothesis is that, those kids with more adversity have more advanced aging as represented by this methylation age, and that their chronologic age is actually lower than their biologic age, and they're aging quickly. What we actually did not find a significant relationship between them. Interestingly, I like ran it a couple of different ways to check was I doing, but we actually didn't see that it was related. It might just be that a lot of what we looked at didn't look at the length of exposure to social adversity. So I would imagine that more chronically you could see that versus we just looked at the number of adverse sort of risk factors. So that might tease it out, but I was somewhat surprised. Part of it too is that we did have a sample of from 6 months old to 18, which the variation in how much aging you can have, we tried to control for by putting in their age, but there's really not that much even standards out there for what normal biomarkers or epigenetic markers are of this age. So that was another thing that we were like, is this normal? We don't know. Is it more advanced or yeah? But that's the one that we looked at there.
I'm very familiar with epigenetic age. We've actually even developed one for neonates, highly dependent on the source of the biological. So
yeah.
Are you going to be using buccal epithelial cells?
Buccal, yeah. So it was buccal, which for ease of collection, a lot of these biomarkers were hair and buccal for that. But it would be great to get more, to get a variety of different samples to sort of tease it out. So yeah.
Very good. Thanks so much.
Sure.
All right, Naomi threw in great work into the chat. So. All right, any additional thoughts or questions for Matt? No, thanks.
I just have,
go ahead, Robbie.
Just one thing that I've been sort of, Matt, just trying to think through one of the earlier things you said about where you showed the elevated levels of IL-1 beta, but reduced cortisone.
Yeah.
Just trying to kind of think through that a little bit because high cortisone levels would be expected to suppress IL-1 beta. So I'm just wondering if the reason you're seeing high IL-1 beta might actually be because the cortisone is lower, and it's actually the cortisone levels that's driving IL-1 beta. And then in which case, there's probably some ways you can try to get at that to see whether that's really the pathway that's driving that. You'd have to do some in vitro studies.
Yeah.
Peripheral blood monocytes from these patients, and it might get kind of complicated. But anyway, I'm just wondering if you have any thoughts about kind of what that network is suggesting.
Yeah, no, that's a great thought right there. And I think there's even ways we could try to look at some of the diagonals, those that with high on both or low, just to see if there is something suggested. But yeah, the pathway I would think because of that would be chronic stress leading to, and some of these studies have shown, less chronic stress, more acute stress, having higher levels of cortisol and cortisone initially, more chronic stress than having lower because of sort of the HPA excess burnout. So I do wonder if, like you say, that represents chronic stress exposure, lower cortisone, and therefore is sort of higher levels of some of these, interleukins like IL-1, which would be, at PAS, I met someone actually at the talk who came up to me and said they were doing similar things. So I'm actually connecting with them later this week to check about it. But I'll bring that up with them as well to see if there's any. The tough thing with these studies has been the temporality, because it's just, even though we get them at 2 points in time, really to look at the dynamics of that have been, it's just 2 snapshots. But I think that's a great point, and I'll bring up with our collaborators that are running the biomarkers.
Thanks.
All right. Thanks, everyone. Again, I'll see you in a couple of weeks.
Thanks, everyone.